So I have a fair amount of data to talk to you guys about today. And I'm doing that because I was told, Sophia had said, that the crowd would be mostly undergraduate students. So the idea here is just to sort of make you think a little bit differently about HIV than maybe the sort of talks that you've had before. So I'll really start by talking about some of the assumptions that I think people have traditionally had about who has HIV, who's at risk for HIV, and where. I'll then introduce this group of people that we call key populations and talk a little bit about what we know about the epidemiology about key populations and the different levels of HIV risk that affect them. And then I'll give some thought and use some case studies to explore what I think are prerequisites for meaningful prevention programming and some thoughts on moving forward. So this is a map of the world. And you know, when you look at low and middle income countries, people have sort of thought of the HIV pandemic in the former Soviet Union and Eastern Europe as really being predominantly driven by parenteral transmission or transmission from injecting drug use. And so these are drugs that come up from Afghanistan through Central Asia into Russia. And it's assumed that with that, it's exclusively an epidemic among people who inject drugs. In Asia, you'll hear, in South Asia, Southeast Asia, you'll hear people talk about more complex epidemics. And so these are some drug use related to drugs that come from Burma into Thailand, into Vietnam, into southern China. You know, you'll talk about some transmission related to same-sex practices, and then some related to heterosexual or high-risk heterosexual transmission. And then when you get to sub-Saharan Africa, where we know is the epicenter of the epidemic, people will always just say, well, this is just all high-risk heterosexual transmission. And I think just even when I was training, and my department chair is here today as when I was training, Dr. Samet, but you know, that was funny to me, right? That like the epidemic would be so different in that part of the world as compared to like everywhere else in the world. And so we spent the last 10 or 15 years really trying to explore, is that really the case? So in terms of who are these populations, so there's a group of people that have been named many different things over the years. So most at-risk populations, key affected populations. The world has kind of landed on key populations now. But what we're talking about are groups of people who are very specific acquisition and transmission risk factors for HIV. And there's sort of these three universal ones, including sex workers, like male, female, transgender sex workers, gay men and other men who have sex with men, people who use drugs, so that's people who use injection drugs as well as people who use non-injection drugs. Those are groups of people that anywhere you go in the world you'll find, and they tend to have higher risks of HIV than do other people. And then there's country-specific key populations, so migrant populations. So, you know, you'll hear about fisher folk around Lake Victoria in East Africa, for example, or around parts of Asia, truckers, miners. So if we can assume that like fishing and trucking and mining doesn't cause HIV, then likely they have other risk factors like being clients of sex workers or same-sex practices, for example. And then you have non-laborers, so internally displaced peoples, and then also, as all of us are perfectly aware of, this massive migration that's going on right now into Europe through Syria and the sort of risks associated with the lack of meaningful treatment access or prevention programming during that migrational period. So I'll start by going through a few of these different populations. I'll start by talking about sex workers. And I think as Sophia introduced, you know, the way that we address risks is, of course, people have biological risks, like you have untreated sexually transmitted infections that mediate HIV transmission. Sex workers are defined by behavioral risks, so by definition, they have higher numbers of partners. There's often very limited condom usage with those partners. But then also the criminalization really of sex work really makes it very difficult to provide services for them. And in fact, as we'll get to, you know, under US government funding rules, I would say as a Canadian, it was illegal to do work with sex workers under PEPFAR 1, under the largest HIV program, from 2003 until Barack Obama came into power in 2008 and then got passed the following year. So we started by doing a systematic review that we published a couple years ago among sex workers. And we had data from 100,000 sex workers and over 12,000 living with HIV from 50 countries. And while that sounds like a lot, what was striking was that meant that 2/3 of countries hadn't done a single study to look at the burden of HIV among sex workers in the 10 years before that. And so that's surprising, right? That sex workers who we've known from the beginning of the pandemic to be at high risk for HIV, there was really no studies. And again, part of that was because under PEPFAR 1, you just weren't allowed to use any US government money to do work with sex work. There's this prostitution loyalty oath that some of you will have heard about that says that, you know, doing studies with sex workers is like, you know, being okay with child trafficking, and or equates the two very closely and basically just outlawed it. And what you see as a result of that is you just have a very limited understanding then of what's happening with these populations around the world. In terms of the pandemic, specifically among sex workers, I think one of the key messages to keep in mind is that the primary risk factor for a sex worker is HIV among their male clients, right? So where the prevalence among, and male clients are just men, right? They don't look any different, they're just men. So, where general population prevalence among men is low in terms of Latin America, parts of Asia, you see burdens of sex workers being low as well. And so they might have a population prevalence of a couple percent. But where we know population prevalence among male clients to be high, including Southern Africa, Eastern Africa, you see extreme burdens among sex workers. So 60 or 70% burden in most countries in South Africa, Lesotho, Swaziland, Malawi, et cetera, throughout really going up east. And so when we wanted to look again, specifically in across Africa, there's sort of this belief that all women are equally at risk. That risk is really evenly distributed amongst all women. And so we did a meta-analysis to look, and what we found was that sex workers had about a 14 times increased risk of being HIV infected than are other women. And so it challenges that notion of saying that even across these epidemics, that everybody's evenly at risk for HIV. That indeed, you start seeing that in fact some women have higher risks than do other women. And understanding those risks probably gives you insight into sort of how to address them. In terms of incidence, prevalence tells us very much about where things were, but somebody could have been infected yesterday or they could have been infected 10 years ago. You don't really know. We want to get at incidence data because that tells us about new infections, where things are going. And you see incidence rates that are as high as 25% in Kenya and South Africa. So just to say what that means is that if you had 100 women that were HIV uninfected, after 1 year, 25 would have HIV. After 2 years, 50. After 3 years, 75. And after 4. So basically after 4 years, except for mortality, everybody would have HIV. And so these are extremely high incidence rates compared to background rates of a couple percent. Okay, so moving on to gay men and MSM. So one of the big differences to keep in mind when we talk about epidemics among MSM, among gay men, is the consistency around the world. So whereas we talked about sex workers seeing great differences around the world, and when you look at the data, this is again based on another systematic review that we did, whether you're looking at North America, Central and South America, Sub-Saharan Africa, Asia, you see about 14 to 18% of gay men living with HIV. And there really isn't a big difference around the world. You see some lower rates in Asia and parts of Europe, the highest rates in the Caribbean. But really, it's sort of this remarkable consistency of that epidemic. And where we don't have data, so in sort of a light, so basically in Central Africa there and moving into West Africa and the Middle East, you really don't have any data. And that's not because there's not gay men or MSM that are there. It's just a sort of an issue around safety of doing these studies, both in terms of participant safety as well as protecting your own staff when engaging in these studies. And so looking at Africa, more specifically, I think one of the things to keep in mind about Africa, and I think is important for you to know, is that it has 4 very distinct HIV epidemic patterns across the country, across the continent. And so in Southern Africa, and moving into Eastern Africa is the only place where you really have these broadly generalized epidemics with population prevalence of 15 or 18%. As soon as you move into East Africa, into Kenya, Uganda, Tanzania, into Rwanda, you see general population prevalence that's more moderate, like 6 to 8%. You move over towards Central and West Africa, and you have general population prevalence of like 1%. So the epidemics start looking more like Asia or Latin America. And then finally, you move into North Africa, Morocco, Libya, Tunisia, and you have general population prevalence of like 0.1%. So these epidemics look more like, very high income countries. And so when you compare burdens of gay men and MSM in each of these settings, you've continued to see that if you compare it appropriately to other men in the same sort of epidemic pattern, they always have higher burdens of HIV, whether it be incidence or prevalence. And so when we first started, there was data from about 10 years ago from Senegal, which is a country in West Africa, and Kenya, which is a country in East Africa. And then basically over the next 10 years, we've continued filling in the map, our team and many other teams, about collecting these types of data. And again, in each of these settings, you see much higher burdens of HIV among MSM. And there's not been a country that I've been to and I've been to a fair number of them, where there aren't groups of gay men that are ready to sort of embark on these types of studies, to engage in them. It's just a matter of safety. And then again, incidence. So we have cohorts, and so this is where we follow people prospectively. We've had cohorts of MSM in Senegal, in Nigeria, in Kenya, or I should say other groups in Kenya, in South Africa, and again, high incidence rates around the continent. And some people will say, well, this is a new thing, right? That this is kind of a new emergence of the pattern, and it's a change. And to counter that, one group has had a cohort, so they've been following MSM, gay men, across for the last 10 years. So going back to about 2006 to now, and they've seen sustained incidence of about 7 to 10%. So it hasn't really changed that much. It's just a matter of the fact that people hadn't been engaged before that. And when we look at the sort of epidemics as a whole, whereas I think it's interesting, there's been sort of a trend over the last number of years to think, well, HIV is being solved, right? That the global response to HIV has solved it. There was a cover of The Economist a couple of years ago that said the end of AIDS. And there have been a lot of countries around the world are seeing decreasing rates amongst those at highest risk. So we wanted to ask sort of what's happening specifically about MSM or among gay men and other MSM. And what we've seen is actually throughout these sort of declines in other settings, we've seen sustained incidence. So this is incidence from high income countries. It's a little cut off at top, but nonetheless, it's incidence going back from 95 to 2015. And you've seen about 2 to 5% incidence over the last 20 years, and that's been sustained. When we look at low middle income countries where we're just really getting these cohorts going, where we're just launching up cohorts to better understand these needs, there's data from across Africa, including our own and others. And where we have data, you can actually see a trend. Of increasing burdens and increasing incidence. And that reality is something that is happening in Los Angeles, as it is in Sweden and Toronto and lots of places, that incidence has continued to increase among MSM as compared to other populations. So some of the groups, I just wanted to bring up sort of some of the groups that tend to not get included in these as well, and that is adolescent gay men or adolescent MSM. So, in the places where I work, it's already sort of challenging enough working with those 18 and above, that working with sort of 15, 16, 17-year-olds is that much more challenging because we would need approval from their parents, and then they would be like, well, what sort of things are you asking and talking about? So what we do is ask people retrospectively, right? We just assess, did you have sex with somebody with a man before the age of 18? And of course, right, coital debut is at 15, it's 16, 17, as it is in many places around the world. So this is country for Burkina Faso, which is a country in West Africa, similarly Togo. And about 50% of the men had sex before the age of 18, a little bit higher in certain parts and a little bit lower in other countries. But nonetheless, what's happening there is that you're having a significant amount of acquisition risk for HIV before the point of 18, which is when the programs are allowed to start addressing their needs. So you're sort of missing of addressing those needs amongst younger men. And where there is incidence data, this is from a cohort in Thailand that's been ongoing for some time. They can see that the highest incidence in blue, basically a 6% annualized incidence is amongst those 18 to 21. And they don't have data from those, again, that are 15, 16, 17, but one would assume that there's high incidence already amongst that group. And so again, they're not allowed to follow people until they're the age of 18, but you continue to see this sort of missed group amongst younger men. And the same thing is true in the United States. So this is data from a colleague of ours, Patrick Sullivan, in Atlanta, where they have a cohort of both among gay men and other MSM. And in blue, you can see the burden of HIV among African American MSM, and in orange, that amongst white MSM. And what you can see is that it's actually pretty stable between 18 to 19. And then once you hit 20 to 24, that's where there's this massive acquisition risks amongst African American men as compared to white MSM. And that is all being missed by current programming because a lot of the programs are targeting 30-year-olds, late 20s, and they're just not effectively addressing the needs of younger guys. And then the last thing I'll say, and this might be a little bit of a complicated slide, is that one of the things that we want to do in HIV prevention is really engage people early, as soon as that they've been infected with HIV or as close to the time they've been infected with HIV, because people have viral load spikes, like their viral load in their blood goes high, the viral load in their semen is high, and that's when they're most sort of infectious in terms of transmitting HIV. to others in their communities. And what this is basically saying, this is based on a review we did a couple years ago, which is to say that the majority of late diagnoses, as we can assess based on viral load when people are diagnosed, as based on CD4 counts when people are diagnosed, tend to be amongst MSM, and that's only increasing. And that's even in places, most of the data come from Europe where you have these nice national surveillance systems, but including in data from the US and Canada, just basically saying this is going to continue for some time because we continue to diagnose people very late, which means that they've already had a significant amount of opportunity for onward transmission by the time we're diagnosing them, and we have to think about how we're going to do better. So moving on to people who inject drugs. So when you think of people, sort of inject drug use epidemics, again, people will think of Asia, in southern China, into Vietnam, drugs from Burma. I was saying the former Soviet Union, Eastern Europe. And so but I'll say the best estimate from sub-Saharan Africa is that there's about 1 million people who inject drugs across the continent. And there's a wide range around that. And amongst prevalence, the best estimate is that it's about 12% prevalence, which means that there's 118,000 people estimated to be injecting drugs and living with HIV across sub-Saharan Africa. And so, where we have the majority of data comes from East Africa, so that's Kenya and Tanzania. And those are drugs that come down. I'm not sure why I'm trying to use a laser pointer, it doesn't work, but nonetheless, those are drugs that come down from South and Southeast Asia, enter there, and then through Tanzania, there's something called the Tanzam Highway, which basically takes you down into Zambia, into Mozambique. So the drugs move their way south from there, although there's no data. Similarly, there's drugs that are moving into West Africa. So these are drugs now coming from South America. That's Cote d'Ivoire there. And there's a kind of a corridor called the Abidjan-Lagos corridor, which is kind of a heavy movement corridor and a lot of traffic and a lot of movement. And there's a fair amount of drug use that goes through there as well. And there's a new drug route going through Guinea-Bissau and southern Senegal. And so Guinea-Bissau is kind of a failed state. But what's happening then is that it's become a common place for drugs to move their way. And basically what they're doing is new entry points, across northern Nigeria, northern Cameroon, and into Europe. And so as compared to the traditional sort of Canary Islands into Spain drug patterns, they're just looking for new ways of getting drugs in. And you can see it with your own eyes. You see these land cruisers that don't belong to the US government that are sort of channeling their way around these rural parts of northwestern Africa, and you sort of wonder. And I think, what people are saying is that, there's a new sort of emergence. We know that the sort of war on drugs, you guys kind of live very close to this war on drugs in Mexico, has not worked anywhere they've embarked on this, right? And so there's a lot of fear now of like sort of re-engaging on a new war on drugs across West Africa. And Kofi Annan, who was the former UN Secretary General, really held a meeting to say, like, let's learn from what had happened in other parts of the world. Let's try and do this in a different way. He hosted meetings, but for now, it's been the same. There's been bombings, there's kind of fighting back and forth, and it's probably not the way that it's going to get effectively solved. So then trans populations, so transgender populations. So there's a Lancet special issue that's going to come out in about a month focused on transgender health. And so again, we did a systematic review to look at what do we know about trans populations around the world. And in yellow, it's where there's been one study done, so in Mexico and South Africa, in Norway. In blue, you have 2 to 5 studies, including Canada, parts of South America. And then in orange, you have 60 plus studies, right, which is the United States. And so, the vast majority of work around assessing trans health has really been done in this country. But when you look at sort of the population prevalence of trans populations, and so this is the review that's been done today, data from US, the UK, New Zealand, parts of Europe, say that about 0.5 to 1% of people will identify as transgender. And that's pretty consistent wherever this has been studied. So even though the vast majority of work has been done in the US, there's a tremendous amount of unmet needs in other parts of the world. We did a review a couple years ago looking at trans health because where I was working, you see when you're engaging gay men in all parts of Africa, you see people who are clearly trans, who are gender nonconforming, but have never really been assessed, whether it be qualitative or quantitative. And so we wanted to try and understand that a little bit more. So we always, as we do, start with a systematic review. And the message of the systematic review was that, for transgender populations, we only had data at that point from 15 countries, and that was both high and low income. But the message was that where we had data, they were the most sort of disproportionately affected by HIV. So more so than gay men, more so than sex workers, and that there was basically a 50 times increased burden of HIV among trans populations as compared to other people. And then, again, Mother Africa was sort of conspicuously white in terms of there having been no data from that continent. And so we use now what is sort of considered the gold standard of around a two-step gender assessment, which means basically what is the gender assigned at birth and what gender do you identify as now? And when we asked this question, so when we first started doing this work, we made the same mistake as many, which was we asked people in like rural parts of Burkina, like, are you transgender? And it's not a term that they've ever heard before, and nobody would say yes to it. But when you ask people like, people who are clearly assigned the male sex at birth, what gender do you identify as? You can see 16% in Burkina Faso will say they identify as women, 20% in Malawi, which is a country towards southern eastern Africa, a quarter of the sample in Swaziland, Lesotho. So similarly, and so the idea just being that in fact there is an emergence of an understanding about the sort of the complexity around gender identity, that this is not just, people will accept that gender identity is complex in parts of Asia, but it's really gender identity is complex everywhere, just really not something that's been studied, but I think something that is very rife for kind of continued learning as time goes on. And so, as sort of an emerging and I think a nice thing is that whereas, you look from 2008 to 2014, in 2009 to 2012, there's about 10 studies across the entire world published on trans health a year. And really only in the last few years are you starting to see more studies being published. And so I think that tells us that we'll learn more about the needs of these populations as we move forward. So I guess it sort of brings us to this question of like, why do we know so little around these populations? And I think, if you look at how HIV surveillance guidelines have emerged, you might come to better understand why it is that we know what it is we looked for. So in the virus was identified in '83, and about 6 years later, WHO came together and made guidelines. And at that point, they basically said, just do surveillance within antenatal clinics, which means when women get pregnant, they go to ANC centers, antenatal clinics, and you can do testing in that, and that would be representative of what's happening in the country. But obviously, you're not testing men, you're not testing young people, you're only testing those that are pregnant, and moreover, you're only testing those that are pregnant and that actually come to a clinic for care. And so it took them about 12 years, and then in 2000, they developed second generation surveillance. And it's at that point that they developed these sort of terms, low level, concentrated, and generalized. I won't get into it, but what basically happened was that countries that had more than 1% antenatal clinic prevalence said, listen, your prevalence is so high, you don't need to do surveillance for specific populations anymore. So you don't need to worry about sampling MSM or sex workers. Just, you have now a generalized epidemic. And I think countries then sort of interpreted that in a very simplistic way, not just as a surveillance recommendation, but just as like an entire HIV response. Like, we're a generalized epidemic. We don't need to do anything for any of these specific populations. We will only target at this sort of hypothetical general population, like this person with sort of this average risk factor for HIV. And so for those of you who've been across, sub-Saharan Africa, you'll see a lot of billboards about like, just be strong, be courageous, like love yourself, or which really, address nobody. Do you know what I mean? But nonetheless, it's the general population. And so the question is just sort of now meaningfully thinking of, it's been another 15 years. What is it we're going to do around that, and how are we going to move that forward? Another thing that's commonly used across sub-Saharan Africa to sort of guide studies are these modes of transmission studies. And I won't get into the sort of weeds around modes of transmission studies, but they're mathematical models that help people understand of the next 100 people that get infected with HIV in your country, who belong to which population. And I only show this as the arrows mimic basically how sex happens. And so, I won't get into the weeds of it, but the newer models are basically saying, obviously sex is complex and transmission is complex. And those studies, as a result of using those modes of transmission studies, really up until just last year, I think, again, we've ended up in a situation where you don't really have any understanding of these specific populations because we haven't really included them meaningfully in our mathematical models. The other dynamic I'll just say quickly is around sort of static versus dynamic models. So, these static models only look at the next 100 people. But a dynamic model, which we and others are using now, are saying, well, if a sex worker has HIV and she transmits HIV to her male client, who transmits HIV to their wife and then maybe has a vertical transmission event, none of that is accounted for in your static model, right? You would only end up seeing these disconnected people, like a wife who has HIV with no other risk factor. But in your dynamic model, you would have a better understanding of the sort of chains of transmission that would have happened. So another piece is that, there's been a lot of talk, and this is, again, building on Sophia's work and others, around the importance of structural determinants of health. And so, you can conceptualize HIV risks in terms of these various levels. So what are the individual level risk factors, like the behavioral issues or the biological issues that I may have that increase my risk for HIV? But there's been a lot of talk for the last 10 years around sort of the value of social and sexual networks. So sexual networks, like larger sexual networks, non-dense sexual networks where I don't know others in my sexual network would increase my risk. Social supports are really helpful. Community level determinants in terms of stigma in your community or access to treatment in your community, public policy. And so we wanted to try and say, well, okay, it's great that there's sort of all this rhetoric around it, but who's actually measuring it, right? Who's including this in our studies, in their studies? And so again, we embarked on a review, and the message just is that I showed you maps earlier with lots of prevalence data around, for these different populations. And we just asked the question, who included like a single determinant of like, not just asking about condoms and numbers of partners, but just anything like, have you experienced stigma? Is there anything? And what we found was, sort of 3 studies from South Africa, that's Uganda and Senegal, from Sub-Saharan Africa. No studies among sex workers had ever asked, like, have you ever been arrested? Has any of these dynamics ever happened to you? And so I think there's sort of this disconnect between the attention that's been given to this and the actual inclusion of this in people's studies. Another dynamic is around STIs. So the vast majority of the continent really focuses on syndromic STI surveillance for sexually transmitted infections, which means you would only get treated for an STI if you have symptoms for it. But what we know is that the vast majority of sexually transmitted infections are asymptomatic, right? So in this country, many others will do sometimes presumptive treatment. We'll often test people using different types of swabs to say, do they have an STI? And so in our cohorts of men who have sex with gay men in Nigeria, we see high burdens of gonorrhea, of chlamydia, but all of them are asymptomatic. So in using a syndromic system, none of these would ever get treated. And similarly, there's data from South Africa that support that as well. Then the use of the internet, right, to find partners. So if I was talking about the use of Grindr or Manhunt or any of those sites over here, it's just everybody would accept that it's a standard way of meeting folks. And then, but there was a belief that across Sub-Saharan Africa, it's just people meeting each other in bars and streets. And so what we asked the question is, do you use the internet to find male partners? And what apps are you using? And of course, as one would expect, they are using the internet. For those of you who've been there, it's not always the best connection, but most of the places are connected. And so, sometimes more than 50%, 40% of the people are finding male partners online. And that is especially the case amongst youth. So I'll just give some specific data around, because one of the things that we also know is that when people find male partners online, they're less likely to know their HIV status, they're less likely to know anything about them, and there's a higher risk of HIV transmission or HIV infection in that. And again, if I was talking about the US, people would take that for granted. It's really nothing, it's nothing new. But when we looked at this across Sub-Saharan Africa, what we find is that people who are using the internet to find partners online are people who are more afraid to walk around in public, are people who have been afraid to seek healthcare services, and those are the folks that are then using the internet to find male partners. But it's also true that those people are much more likely to have HIV. And so when you adjust for all the other determinants. And so the message there is that this dynamic of what's happening in LA is probably very similar to what's happening in Lesotho. That biology is biology and people are people. And hopefully that's sort of one of these trends that'll come out of this talk. Another determinant is depression. So again, if I was to talk about minority stress, both from sexual identity or gender identity, again, I don't think anybody would be surprised if I was talking about LA. But what we were using for a long time was just a PHQ-2, which is a primary health questionnaire 2. It's a very brief screen, a 2-question screen around active depression. And what we noted was that because 60 to 70% screened positive, we changed to a more refined measure. And the message here was just that, first of all, 50 to 60% of the people screened positive for active depression at the time of the survey, but also the clear relationship between that and syphilis active syphilis at the time of testing, as well as having been diagnosed with an STI in the last year. And so again, here the message between the relationship of depression and STIs is common, but it's the same thing that we see in other settings. So this is a structural equation model, and without a laser pointer, I'll just say that if you start at the end, and you say, the vast majority of public health programs or HIV prevention programs will try to do things like address numbers of partners or condom use or, partner concurrency, which means having sexual partners at the same time. But what you find is that there's a clear sort of antecedent relationship between depression, substance use, and those ultimate outcomes. And even sort of upstream from that is stigma as a clear determinant. And so what it basically says is, and there's actually no direct relationship between stigma and risk practices. And so what it basically says is that if you try and do prevention programming to say, have less partners, use more condoms, without sort of addressing the determinants of those sexual practices, you'll likely have limited benefits, right? That you really need comprehensive programs that address mental health, that address substance use, and that address the experiences that people have in order to have outcomes. So then, just quick second part of this talk is around different types of programs. So we know that the sort of HIV response now is made up of combination programming. You need behavioral approaches. You need biomedical approaches. Some of you guys will have heard of pre-exposure prophylaxis, like using an antiretroviral pill a day, which works very effectively to prevent HIV. Vaginal microbicides for women, universal test and treat, and then structural interventions. And so the idea is that these packages have to happen in unison. And similarly, there's a continuum of care. So there's a whole series of studies that have come out this year that basically support, so the START study, the Temprano, HP 10052, that basically say, if you can take somebody effectively through this cascade of being at risk for HIV, of knowing my status, of getting linked to treatment and achieving viral suppression as early as possible, I'll have the best clinical benefit myself, and I won't transmit HIV to others that I have sex with, almost universally, condom or not. And so the question I really ask is, what are the things that you need in order to meaningfully achieve coverage and scale of the prevention programs I just talked about and engagement in HIV treatment? So you have to be able to identify people, right? They don't look any different. You have to be able to identify those who are at high risk to, again, test them early, engage them early, achieve viral suppression. You have to be able to stratify the risk. Not all gay men are good candidates for PrEP. Not all sex workers would be good candidates for vaginal microbicides. Some will have more risks and thus need those programs than others. And you have to be able to see them twice. And so, a few years ago when the whole program was just throwing condoms at people, it's okay if you never saw them again. All that would have happened is you gave them a condom and you never saw them again. But if you're going to initiate somebody on treatment, you have to see them again. If you initiate people on treatment and then never see them again, you've actually done them a disservice. That happens all the time, but you've actually harmed them and everybody they have sex with after that because of issues around resistance and whatnot. And so you have to be able to achieve those things. So I'll just give two very brief examples from Swaziland and then, because Laura's in the room, from the Gambia, two places where we've worked. So Swaziland is one of two little mountain kingdoms it's sort of between South Africa and Mozambique. And it has this sort of unfortunate notoriety of having the highest prevalence of HIV in the world. And so in red here, or in orange, you can see what is the prevalence just among sort of all women. So by the time they're 16 to 20, it's 10%. By the time they're 21, 34, right, they're already 40% are living with HIV. Again, all women. And then you get up to 25 to 29, you basically have 50% prevalence. And so in this setting, again, when we did a study among sex workers, and among sex workers in blue, you can see that for those 16 to 20, it's already almost 50%. And it just goes up from there, that 25 to 29, it's basically 80% and going up. So we're talking about 8 out of 10. The overall prevalence was 75% amongst the 400 or 500 we sampled. And so you're talking, and they're mostly sort of 24, 25 years old, 8 out of 10 living with HIV. And so the sort of message epidemiologically is that risk is not evenly distributed even in this most generalized of HIV epidemics. But around sort of identification, what you can see is that we ask these determinants like, are you afraid to seek healthcare? And you can see almost half the sample, 40% are afraid to seek healthcare, have experienced legal discrimination, have been blackmailed. Over 50% reported having been tortured, which in qualitative work meant basically like repeated rapes and violence in single episodes. And the most common perpetrators of these are uniformed officers, right? So it says the challenge of sort of doing anything about after these events. And so we asked the question, how many had even ever disclosed that they're a sex worker? And about 30% had ever disclosed to a family member. Only about a quarter had ever disclosed to a healthcare worker. And it begs the question around, why? And so what you find was that amongst those that had disclosed to a healthcare worker, they were far more likely to be afraid to seek healthcare. And that was especially true amongst those living with HIV. And so it sort of brings us to that question that if people, this is again a group of people with 75% HIV prevalence, are afraid to seek healthcare, especially amongst those living with HIV, how can you achieve sort of sustained treatment amongst those people? And I think that's especially important in the context. So officially, we're not allowed to advocate for decriminalization. That's still true even under Barack Obama of sex work. But what I can say is that the data, this is modeling work from Kate Shannon that was published in The Lancet last year, says that basically if you create a safe work environment like you might see in Amsterdam or other parts of the world for sex work, you can basically prevent 40 to 50% of infections among sex workers and their clients over a 10-year period. And so I think the data speak very closely to the fact that that this is an important element. And some of you may have seen the sort of hoopla around Amnesty International calling for decriminalization of sex work. Obviously, Sophia was quite involved in that whole element. So moving on to the Gambia real quick. So the Gambia is kind of a funny place. It's almost like a North Korea in terms of like political dynamics. And so that is a country you're more familiar with than the Gambia. But nonetheless, it's a little pizza slice out of Senegal. And so it's a little British colony within kind of a French colony, and right beside Guinea-Bissau, which is a Portuguese colony. All of them speak the same language normally, but it's just sort of like colonial games that I think created these funny borders. But nonetheless, so this is a country, as I said, in West Africa, more concentrated epidemics. The general population prevalence is about 1%, and amongst MSM, it was about 11%. So in 2012, there was just a large arrest of young gay men that happened. And a friend of mine sent me the statement of offense, and I always think it's interesting to read it. But it basically says, the statement of offense says you have attempted to commit unnatural offenses contrary to the section of the Criminal Code of Volume 3 of the Laws of Gambia. It says you jointly attempted to commit an unnatural act by conducting yourselves in an indecent manner in a public place, thereby you committed an offense. And it says you jointly conspired amongst yourselves to commit a felony therewithin to finance the occasion in which an indecent act was about to be committed. And so it's interesting that obviously nothing happened. So this was a party that happened at a bar, a public space, and just was really raided by the police. And so it's almost funny to read, but the outcomes are less funny, right? So the Gambia is a predominantly Muslim country. We just collected some of the media that happened over the next few months. This is an imam, so imams are very powerful in that setting, calling for death and hellfire for homos. Coco Ocean is a big hotel there. And then, this is President Jammeh, who's kind of like the Kim Jong-un of the Gambia. And so the African Union has their Human Rights Commission based in the Gambia. So he won the bottom one says, another prestigious award for Jammeh on the same day that Operation Bulldozer, which was to bulldoze out homosexuality in the country, was launched. And so it was just kind of an interesting newspaper cover. But nonetheless, this has really continued that, threatening people from coming, continued arrests, and then also the anti-homosexuality. So whereas a lot of us heard about the Uganda's Kill the Gays and ultimately Jail the Gays bill, but was ultimately repealed. In the Gambia, they use the same language, but it's now law. But that just kind of gets less attention. So in our study, we asked the question among MSM, how many had disclosed? And as you could imagine in this dynamic, only 4% had ever disclosed to any family member that they have sex with other men. Only 15% had ever disclosed to a healthcare worker. And amongst those that had disclosed, again, they were 2.5 times more likely to be afraid and nearly 10 times more likely to have been denied healthcare. So it says that in this setting, although from a public health perspective, we want them to disclose, we want to better address their needs, there's really clearly little value when they're getting thrown out of clinics. And in Nigeria, this idea of criminalization, the effects, many people will say, well, criminalization is at such a high level, it doesn't affect the actual programs. And what's interesting, and some of you will have heard about the same-sex marriage bill that was put through in Nigeria in sort of January 2014. What that said was that it further criminalized same-sex practices. Same-sex practices were already illegal in Nigeria, but what it did was ban marriage and ban association with any group. And so because we had a cohort, we were following groups of gay men and providing them services, we had the opportunity to really sort of assess what would be the effect of this. And the short of the message is that, you know, in light gray, you'll see sort of before this law went into place, and there was already a lot of fear, a lot of discrimination, but in black, you see just the only difference here is a month later, and the bill is now in place. And you see a tremendous amount of increase in fear of seeking healthcare, fear of engaging. And this is a group of people, again, with 16% HIV incidence, nearly 50% prevalence. And similarly, when the law here, you're seeing in gray before the law, this is fear of seeking care. You see a significant increase in fear of seeking care after the law goes into place. So it just basically says these laws do matter even at the ground level. They affect how people engage. And so what ultimately happens, this is from the MSMGF, among 6,100 gay men around the world that engaged in this study, only 57% had even ever tested for HIV, right? And so, you know, when you actually look to see who's achieved viral suppression, you see that the vast majority of men are walking with undiagnosed HIV infection, and it's because of a significant amount of fear of seeking care. So the sort of messages here are that, you know, you can't achieve any of the new advances in HIV, whether it be PrEP, microbicides, treatment, if people are afraid to seek health care, if they're hidden in terms of lack of disclosure, and they're not engaged in clinical care. So the themes of the talk, just to finish, is to say this, that, you know, we know the least amongst populations where there's the most stigma, right? So those are the places where it's the hardest to work, and it's the least safe for people to engage in those studies. But, you know, the world, if you look at it, where we have data, is pretty similar, right? Risks for HIV are universal. And where you look, you know, gay men, MSM have higher risk than do other people. It seems to be the highest among young folk. And trans women tend to have higher burdens of disease where we can assess that. And to sort of move forward, obviously, the idea is that, you know, just condom programming is not going to get us there, right? That we have to address the sort of broader determinants that affect why people do or don't use condoms. So lots of people to thank, but yeah, thanks.